In this video, I'm going to be talking about the transition between first line and second line therapy based on a recent clinical trial called the Armani study at a recent annual meeting at the American Society of Clinical Oncology, ASCO 2024. And it is going to be building on previous videos, which I encourage you to look at as a background that focused on first line therapy, why we do it, how we do it, and the rationale, and also second line therapy video looking at why we do that and how we do it, and also a video about first line maintenance in between first line and second line. And so now this study comes in as a question as to when we should start second line therapy. So again, as a background, we're talking about after a patient is newly diagnosed based on a number of diagnostic studies and they have staging done. Again, there are videos specific to that that I encourage you to see. And we're talking about patients who have unresectable, for whatever reason, cancer. So either metastatic disease outside of a surgical field and or locally advanced, invading into organs that make it not amenable to surgery safely. So we call this palliative therapy. And so in our mind map, we've gone through first line therapies using backbone chemotherapy, typically FOLFOX, sometimes triplet chemotherapy regimens. And we talked about second line therapy based on biomarker statuses. Specifically, now we're talking in this study that we're going to go through HER2 negative in second line, a typical regimen being paclitaxel and ramucirumab, but also we can consider FOLFIRI as a backbone option. And then again, as I mentioned, we also talked about first line maintenance therapy in between to transition between first line and second line. So again, I would really encourage you to get those videos under your belt so you understand that before we go to the next topic. Now, the reason why this study Armani is being done is because, as we've also alluded to before, is that even though we know we have effective therapies in second line and even later lines, as time goes by, only about 50% of the patients who start first line therapy go on and get second line therapy, and even fewer go on and get third line therapy and higher. And the reasons for that include patients that have really aggressive cancer, despite even being very vigilant, they just progress so quickly, and their physical condition, which we call performance status, deteriorates so quickly that we just can't go on safely to get next line therapy. In addition, sometimes patients pass away quickly while on first line therapy. And so, of course, we can't get on to next lines of therapy. So again, this is the whole rationale: is what if we start second line therapy a little bit earlier so that everyone gets a chance at getting that. Again, a quick summary about what we can expect with first line chemotherapy. First line chemotherapy, again, typically is FOLFOX. Generally, most oncologists try to avoid the alternative platinum drug, cisplatin. Other regimens that could be used in first line include FOLFIRI, which is 5-FU and irinotecan instead of oxaliplatin, if a patient isn't a good candidate for oxaliplatin, for example, if they already have neuropathy for another reason, and so you want to avoid worsening that. What we can expect from outcomes with first line therapy in general, again, this is looking at large statistical analyses and large populations. It's not specific to any one individual, but if we look at a large group of patients getting first line therapy, about half or 40% we would expect to have shrinkage on scans, or what we call overall response rate. And that means that it's shrunk at least 30% from what it started as. Disease control rate is higher. So even though it's not shrinking, at least it's stable. So this disease control rate includes those who either have a response and or those who have at least stability of their cancer. It's not growing. So that can range depending on the study you're looking at, but it is a high percentage of patients who at least will get control, at least initially. And then progression-free survival, which is the time point at which the cancer starts growing on the particular regimen that you've started with. And this is a median number. Again, it's a wide range around that median. All this means is that about half of patients that have started first-line therapy will have their cancer start growing after about 6 to 7 months, whereas half will not. And then survival, overall survival, about half of patients are no longer alive after about a year, especially now with better therapies and later line therapies available, about a year median overall survival. And each of these parameters are improved a little bit and incrementally when you match a targeted therapy based on a biomarker if it's present in the patient's tumor. Okay, so this is what we can expect with first line therapy. But eventually, as we talked about, cancer eventually becomes resistant to any given therapy in general. And so there will be a time to switch to the next backup plan, so to speak. And so reasons to change are obviously if there is obvious cancer progression, despite being on our full chemotherapy planned regimen with or without a targeted biologic therapy, if appropriate, given on the biomarker status in the tumor. In addition to that, if a patient has progression when they're on maintenance therapy, which remember that means you're on the 5-FU part of, say, FOLFOX, but the oxaliplatin is stopped intermittently just to give your body a break and to limit neuropathy and other side effects, with or without, again, a targeted therapy as appropriate. But you have disease progression, and then you can't resume the oxaliplatin because you have such bad neuropathy, you don't want to make it worse, or other things like if you had an oxaliplatin reaction, an allergic reaction, so you want to avoid that. So even though it hasn't progressed on oxaliplatin, you would still switch to next line therapy. And then the third one, which I've even starred this time, is a really important one, and it's very pertinent to this discussion here with the Armani study, is that we still want to be changing, even though there's no obvious cancer progression on scans, even on tumor markers, but there's a clinical concern of progression. There's more worsening symptoms, or there are signs that the oncologist can pick up that they think that the cancer's progression, even though the scans are not suggesting that. And we've talked about a classic example of this is with peritoneal only gastric cancer, for example, where it's not visible on scans to begin with. But so we're trying to assess how we're doing with our treatments, and we have to be very vigilant in terms of when to switch to the next line therapy. And so, again, this is really pertinent to this particular topic that we're talking about today. So whenever we do switch to second line therapy, the goals of second line therapy are the same as they were in first line, and that is to control the cancer as long as possible, while limiting side effects from the treatment and improve quality of life for as long as we can. But eventually, again, even with second line therapy, we will expect some resistance to occur in some of the cancer cells at some point. The outcomes that we would expect with second line treatments, the response rate is a little bit lower than what was for first line. If you go back to that slide, but it's still around 30% with optimal second line therapy in ramucirumab-based studies. Disease control rate, again, a little bit lower than first line, but still reasonable and warrants trying to use second line therapy to keep things controlled for a period of time. The progression-free survival and overall survival medians are a little bit lower, again, with second line therapy compared to first line, but again, better than the alternative of not doing anything. And so this is the benchmarks that we would expect with second line treatment and the reasons for doing it. But again, only about half of patients that start first line therapy go on to get second line therapy. And so this is where Armani comes in, is to ask the question, what if we switch earlier to second line? Even though the patient hasn't had progression on first line therapy, what if we just switch earlier to second line therapy? And again, this is a summary here in this table of recent large phase 3 studies and one phase 2 study. The first two are Checkmate 649 and Keynote 859 are looking at nivolumab, Opdivo, and pembrolizumab, Keytruda in first-line therapy along with FOLFOX. And you can see that there's a really low percentage of patients in both of the arms of the study, those that got the control arm or those that got the actual immunotherapy drug, that less than 40% in some cases, or certainly less than 50%, got subsequent therapy or next line therapy. Even in studies that were selecting patients based on a biomarker, like the Spotlight and Glow studies based on Claudin 18.2 for zolbetuximab, the Keynote 62 study, one of the first immunotherapy studies for gastric and G-junction cancers, was selecting for only PD-L1 positive tumors by a score of CPS 1 or higher. And for the FIGHT study, which is a smaller randomized phase 2 study looking at FGFR2 expression in gene amplification and treated with bemarituzumab, an FGFR2 antibody. These 4 studies were selecting based on those biomarkers. And as I alluded to in those respective videos, that when we do that, patients have to wait around for several weeks, sometimes even longer, to get the result to see if they're eligible. And so inherently, those types of selecting studies, patients that are really sick at diagnosis, have a lot of cancer, have a lot of symptoms, can't wait around. And so by default, they're not included in those studies. And so we select for a better prognostic group in both arms of the study. And I think, in my opinion, that's why these percentages of patients are a bit higher who go on to the next line of therapy, because we've selected for patients who have a better biology, better status at the beginning. In addition to that, there's the possibility that they're getting specific targeted therapies, and so they're doing a little bit better. So both groups go on and get next line therapy, but these patients are getting, the immunotherapy, and their rates are lower. So I think it's more that there's a selection that's going on to begin with. So the summary, though, of this slide is that a lot of patients who start first line therapy don't go on and get next line therapy. And so one other thing I wanted to point out is that in our Pangea study, which stands for Personalized Antibodies for Gastroesophageal Adenocarcinoma, so a lot of studies have acronyms for their study. We tried to make ours actually stand for something. Regardless, in our study, which was a sequencing study through multiple lines of therapy, all the patients who started first line therapy who had progression of their cancer, almost 90% of our patients went on to second line therapy. And so I think this speaks to the experience of the team treating you and being vigilant and not missing the window or the opportunity to go to second line therapy. So, and we're going to talk a little bit about that as we go through the study. So that brings us then to the Armani study, which is a study that was reported, phase 3 study at ASCO this year, a few weeks ago. And it was performed by the Italian group. And so not surprisingly, they named the study the Armani study. And so that brings us then to the Armani study, which was presented again at this year's ASCO 24 a few weeks ago, and presented by the Italian group. And so not surprisingly, their study was called the Armani study. And you can see here, I'm in my jacket and suit. This was me earlier when I used to have hair. No, I'm just joking. So anyway, this study is ramucirumab, the assessment of ramucirumab as switch maintenance, and then the rest of this deteriorates. I'm not sure what this stands for. So the summary here is that it is looking at moving second line therapy with paclitaxel and ramucirumab earlier, something they call switch maintenance, versus just continuation of the oxaliplatin-based first line chemotherapy as would be considered standard. And this was only for HER2 negative tumors. And so the assessment here was using this switch maintenance early and to assess whether this was superior than just continuing with first-line oxaliplatin-based therapy. And it was done after 3 months of the first-line FOLFOX or CAPOX. Remember, this is capecitabine and oxaliplatin doublet chemotherapy. And so everyone that was enrolled had 3 months of prior FOLFOX and CAPOX therapy. This is the slide from the discussant, Dr. Yeboah, showing pictorially what was going on, is that as you transition from first line to second line to third line, classically, you would switch at each time point when the cancer has progressed on any given line of therapy. But here, the concept was, let's just move it early, right after everyone has had 3 months of therapy, and compare to see what happens. Again, the rationale being that about half of patients don't ever get to second-line therapy. So let's try and give it to everybody early. So this is the schema of the study. That original 3 months of chemo was called induction chemotherapy, and it was done before patients enrolled in the study. So patients were diagnosed, they started standard palliative first-line chemotherapy with FOLFOX or CAPOX, got it for 3 months, and then they were reassessed. And patients were only allowed to enroll in the Armani study at that point only if they had either stable disease at minimum or a partial or complete response. And so patients who had shrinkage of their cancer and or those who had stability of their cancer. And so patients were enrolled, they were randomized to staying on the same regimen of FOLFOX, CAPOX, and for 3 more months, and then going to maintenance 5-FU therapy, first-line maintenance therapy, or to introduce paclitaxel or ramucirumab earlier. Again, I mentioned this was only for patients with HER2-negative tumors. Something also to note is that there's always a list of criteria to be eligible for the study. I again recommend you go back to our clinical trials video. But you can see I'm just highlighting a few important ones here. It was HER2 negative. Patients who had their 3 months of FOLFOX or CAPOX chemotherapy had to have any side effects, adverse events resolved to very minimal or mild by the time they were enrolled in this study. So they couldn't have really bad neuropathy, for example, to continue on this study. And then, as I mentioned, patients had to have at least disease control, if not shrinking, after those 3 months of therapy with the FOLFOX or CAPOX. So a question might be, how many patients actually do fit into that criteria, that category of being HER2 negative and being at least stable after 3 months of therapy? So we can go through clinical trials and look at the progression-free survival curve. So on this side, it's the left versus the right, which is the overall survival curve. Progression-free survival curves are showing that over time, the percentage of patients that are still stable or not progressing goes down, right? And so this is a study that's an older study I had shown when we talked about the difference between triplet chemotherapy, in this case with docetaxel, cisplatin, 5-FU, versus doublet with cisplatin, 5-FU, and showing that the progression-free survival and overall survival are slightly longer with the triplet regimen at the expense of higher side effects. And so why I'm showing you this here now is that you can see that at the 3-month mark, that already in the doublet arm, just under 40% of patients, and with the triplet arm, around 30% of patients have already had disease progression. So at 3 months in this older study, the chemotherapy in first line already had stopped working in a substantial subset of patients. And so these patients would already be switching to second line. The Armani study is talking about, of the patients that are still stable after 3 months, what if we just switch earlier? Can we do better? And so if we fast forward to more recent studies like the Spotlight and Glow studies, what we see here is the Spotlight progression-free and overall survival curves, is that the 3-month progression-free survival rate in both arms, in this case, with say just FOLFOX or FOLFOX and zolbetuximab, is 90% of patients are at least stable. So only around 10% of patients here are progressing after 3 months. So it's variable over time in the different studies that you look at. And so again, we can even look at the immunotherapy study recently done that was Keynote 859, looking at pembrolizumab with FOLFOX or just FOLFOX alone. And you can see that in all the patients enrolled, irrespective of the PD-L1 status, the PFS rate was 75%. So 25% of patients had already progressed at 3 months. And if you look at the higher PD-L1 scores, 20% had already progressed in the CPS 1 or higher, and in the CPS 10 or higher, only 10% had progressed at 3 months. So this is just to, again, reiterate that the higher the PD-L1 score, the better the treatment does, and is controlling the cancer better, even at 3 months better. But regardless, there will be a subset of patients that even at 3 months, there will be progression. And so for those patients, obviously we're going to second line. But again, the Armani study is now looking at amongst the patients who are still stable after 3 months, what if we switch earlier? I wanted to just point out, both in the Spotlight study here and in the next study, 859, that there are a lot of patients that are still stable at 12 months, 24 months, even 3 years later with just first line therapy. And so for me, switching to second line is way too early for those patients. Similarly, in these curves, especially in the high PD-L1 with pembrolizumab or Keytruda, that there's still a substantial subgroup of patients that at 2 years, 3 years, they're still stable on first line therapy. So why switch to second line therapy after just 3 months in those patients would be the question or the counterpoint to the Armani study. But regardless, back to the Armani study, how was it conducted? This is the statistical slide just to show you how they calculated how many patients they needed in each arm to show that the progression-free survival in the Armani switch maintenance to paclitaxel ramucirumab earlier, or arm A, would be longer or better. The progression-free survival would be better than just doing what we normally do and staying on FOLFOX. So this is their calculations as to how many patients they needed in the study. They also, of course, other endpoints was overall survival. So the primary endpoint was progression-free survival. The overall survival was a key secondary endpoint. And for oncologists looking at this, it would be pretty much assumed that the progression-free survival would likely be better by switching to the second line therapy earlier, because they're new agents. The cancer has not seen that therapy yet, and so that would be given, that it would control the cancer better. But the real question that any of us would have is, does it make a difference in the long run? Because eventually, if patients on first line FOLFOX and are on that, as we traditionally do, switch to second line therapy, we know they benefit. And so does it really make any difference to switch earlier, as long as patients get second line therapy is the critical point. So this is what the schema looks like. 280 patients were enrolled and then randomized to switch maintenance early, paclitaxel RAM, after 3 months of the FOLFOX induction therapy, or just stay on standard first line therapy until it stops working and then switch. And the outcomes are shown here. So the progression-free survival, which remember is the main primary endpoint of the study, was better in the patients who switched to paclitaxel and ramucirumab early. That's in the red curve. And the patients who were on the FOLFOX and capecitabine are the blue curve here. And so what we see here again is that after 3 months of FOLFOX therapy, switching to paclitaxel and ramucirumab seemed to control the cancer for a longer period of time compared to just staying on FOLFOX and CAPOX. Again, as I mentioned, this is not surprising to most of us because we're switching to an active regimen. The real question, though, is, did it make a difference in the long run in terms of survival? And so what we see here is that the median overall survival was incrementally better in the paclitaxel and ramucirumab switch maintenance early arm compared to just staying on FOLFOX and CAPOX. We have to also remember that these medians, you have to add 3 months, because we already had 3 months of therapy outside of the study as the induction treatment. So the median survivals from the time of enrolling into the study are a little bit better. And so this is an improvement in overall survival and progression-free survival, the primary endpoint, and secondary endpoint with survival. Other secondary endpoints are the response rates, and you can see that first, that even though after 3 months of FOLFOX chemotherapy, in the continuation of FOLFOX chemotherapy, some patients experienced more shrinkage, or a response rate of 16% after already being on for 3 months. And the response rate was not much higher in the investigational arm of paclitaxel and RAM switch maintenance. However, the disease control, the ability to control the cancer, was higher. in the paclitaxel ramucirumab, which is what we saw in the progression-free survival curves. So there was more patients having stability when they switched early. This is an important slide to show what happened after the patient progressed on the FOLFOX and CAPOX continuation or the switch maintenance to paclitaxel and ramucirumab. So after they started these things, when they progressed, what was the rate at which they went on to something else, and what was that? And so you can see that it was similar across the two arms. So when they progressed, about just under 60% of patients went on to something else. Technically, this was second line therapy for arm B. For arm A, it was the third regimen because they'd already now had FOLFOX and paclitaxel ram, even though they hadn't had progression on the first FOLFOX. And you can see that in the arm A, some patients doubled back to FOLFOX because, again, these patients had not experienced progression on the FOLFOX, whereas these patients who had continued on the FOLFOX and CAPOX, most did not continue that at the time of progression. Most patients went on to standard second-line therapy as appropriate there. But again, only less than 50% actually got paclitaxel and ramucirumab. A large proportion of patients went on to irinotecan and in both arms. So again, as their third therapy for arm A and as their second therapy for arm B. And as I've been alluding to in a lot of our videos, this is my preferred second line regimen because it limits the worsening of neuropathy with paclitaxel. But you will note that this is not with ramucirumab as opposed to the paclitaxel. So adding the Armani results to our table in terms of what are the percentage of patients getting next line therapy, you can see that this is in line with what we would expect from a lot of the other studies in terms of in the control arm, that just 50% or just over 50% of the study are getting second line therapy. And so this may be why the Armani study was positive, is because you're actually getting everybody second line active therapy early. What is the cost of switching to paclitaxel and ramucirumab early in terms of clinical toxicity? And you can see here the side effect profile of any grade. Remember, we grade side effects from grade 1 to 4, 4 being serious, 1 being mild, and everything in between, and the rate of grade 3 or higher in the second column of each arm. And so the highlighted ones are the neuropathy, the neutropenia, low blood counts, high blood pressure from the ramucirumab, and blood clots. You can see are higher in the any grade or grade 3 or higher in the paclitaxel ramucirumab compared to the FOLFOX control, as would be expected. And so, but not unexpected rates for paclitaxel and ramucirumab. So the authors concluded that this study, Armani, switching earlier to second-line paclitaxel and ramucirumab increased and improved the progression-free survival, the primary endpoint, and overall survival, the secondary endpoint, at the expense of higher grade 3 side effects, but not unexpected from that regimen. And that they suggest that this may be a new strategy after 3 months of first-line therapy. They do note and acknowledge, though, that this is in HER2-negative patients, but that patients weren't getting targeted therapies, immunotherapy for, especially for PD-L1 high tumors, and newer drugs like zolbetuximab for Claudin 18.2, which is still to date in June of 2024. We're still waiting for an FDA approval for that here, but eventually that will come. And so how does this study get applied in the context of where we have targeted therapies? I showed you the curves for both of these progression-free survival curves, where a large proportion of patients have stable cancer for a long time. And so why switch early after only 3 months in those particular patients? And so again, Dr. Yeboah, the discussant, points this out, that there are a lot of biomarkers that are established or emerging, that their outcomes are even better than just with chemo alone in their matched groups. And so how does Armani fit in with this and switching early to second line? And so she summarizes, and I agree with her, that earlier introduction of the ramucirumab and paclitaxel after just 3 months of first-line therapy did seem to improve progression-free survival and overall survival at the cost of more side effects. And this is because, again, with first-line therapy, we switch to first-line maintenance. We limit side effects. We go on and off the oxaliplatin intermittently, and we can sort of elongate how long first-line therapy works and make it better tolerable, as opposed to sort of the full second-line therapy after 3 months. So you're going to expect higher side effect profile. And so she asks, is this practice changing? And so it may be for some patients, especially those that have biomarker negative tumors. However, she, as do I, am worried about adopting this sort of across the board blindly in everybody, because a lot of patients have great response and do very well on first-line therapy and maintenance therapy and even chemo holidays on first-line therapy for sometimes years before they need to go to second-line therapy. And so for them, it's way premature, I think, to start second-line therapy. And so we've not seen the difference in outcome based on those who had a response on their first-line induction chemotherapy after 3 months versus those who were just stable. And I suspect that switching early, like in the Armani strategy, to paclitaxel and ramucirumab will be most useful and most reason to do so in those who are stable or just barely stable on first-line therapy after 3 months, compared to those who are doing remarkably well with a nice response. Of course, those patients who have other reasons, as I had started earlier, their scans still look stable, but you have a sense that there's progression because there's some vague symptoms getting worse or tumor markers are increasing. These would be patients you want to try and switch sooner rather than later and not miss the opportunity to switch to second line. But those who are doing really well, scans look great, symptoms have resolved, you've had a nice response on scans, to me, there's no reason to switch early. So the key takeaway, I think, of the Armani is we don't want to change too early, even though the Armani study was doing that in everybody after 3 months. But of course, we don't want to change too late. And it's too hot and too cold, and we want it to be just right. And so this does rely on the experience of the physician treating you, and also from your perspective as a patient and family caregiver, is reporting symptoms, so that even though if scans are looking okay, we're noting that there is something else that might be brewing. And that's where you want to switch sooner rather than later and not miss the chance to switch to second line therapy, because then things are too far along and you're not well enough to get the second line therapy. Okay, so that is the summary of the Armani phase 3 study. So in this video, I went briefly through the rationale and the ways we use first line and second line therapy when we switch, alluded to first line maintenance therapy. And then we focused on the question of what if we just switch everybody after first line therapy after 3 months, as long as it's at least stable, to second line therapy earlier, with the rationale that so many patients don't get second line therapy. Let's just try and give everyone second line therapy early. And that study, with the primary endpoint progression-free survival and secondary endpoint overall survival, were improved. And so, which is good to know, and I think reinforces what a lot of specialists in this disease have always said, is that we don't want to miss the chance to switch to second line therapy in a subgroup of patients. But at the same time, I would want to caution that we don't want to switch too early in so many patients that are doing well. And again, that comes to the experience of the physician. And again, we talked about making sure you're reporting any symptoms to the oncologist so that they're aware and they factor that into the decision as to when to best transition to next line therapy. Stay tuned for the next videos, which we're going to be focusing